I'm Antonio Marttos from the University of Miami and from the Panamerican Trauma Society. With countries around the world, and I use this group through the Panamerican Trauma Society and the University of Miami for the last 10 years to help each other and to act in some disaster mass casualty situations. So today and for the next weeks, we're going to be joined every week to discuss the lessons learned around the world in this COVID-19 situation. And the idea, we're doing this in collaboration with many other trauma societies and medical societies around the globe. And Dr. Aboutanos, representing the International Committee for WCTC, are going to tell during his report the other societies that are going to be joined. They're part of this network of collaboration. So I would like to start saying that this meeting is open. We can have people not in the medical field watching this. So everything is open, and I can even have press or media watching this. So please be aware about this and just say things that you are really intending to say. Okay? When you do a webinar, you don't have a control about who is watching this. The idea is due to provide awareness about what's happening, to try to help each other to manage the situation. So initially, we're going to have Dr. Hayato from Italy and his friends and his colleagues giving a 15 to 20 minutes report about what's happening in Italy. And then we're going to have all the other panelists to talk 2-3 minutes about what's happening in the region. And afterwards, the panelists are going to be discussing between themselves and answering questions from the other audience, the attendees. Every week, you're going to try to rotate and have different panelists to do this. And this meeting we're going to have every week until this situation, this pandemic ends, okay? So please, Dr. Hayato, I'd like you to introduce your colleagues from Italy to start the presentation. Thank you.
Okay, thank you, Antonio, and hello to everybody. So I'm very glad that Dr. Pietro Bisagni and Dr. Enrico Storti, that are respectively the surgeon and the intensivist of the Lodi area, can attend. They are actually our real heroes here in Northern Italy, because everything started in their hospital. And so they were really the first responder. I'm very glad also my former mentor, Mauro Zago, is attending. He is living, he is working in the northern part of Milan, quite in the mountains, but his hospital has been really hard hit in these past days, as all our Northern Italy hospital. So if you agree, I can start with this short presentation. I think it will take 12 up to 15 minutes, not more. It's kind of an update of the presentation that I had last week. Valeria, can you set the presentation, please? I think you should open completely the screen, Valeria. And anyway, this is our region. This is Lombardy. And you see on the left, that was the beginning of the outbreak. The first case number 1 was on February 20. What it is important to remember is that 24 hours later, we had 36 cases, just right away. So we immediately understood that probably we had a second cluster. And then you can see on the right what happened just 1 week later regarding the outbreak. We were quite, the local health authorities were quite rapid to close the area, but that was not enough. The area, the Lodi area and the Codogno area where it all started was closed quite immediately, but that was not enough, because after that we started to see different clusters all over the region. Next slide, please, Valeria. Okay, so as you can see, this is the distribution of the infection of the patient last week. And sorry, it's the last dot, the one on the top, it's not 1 week ago, that's yesterday. So you see, in a week, we really increased again many cases. The lockdown of the whole country lasted 10 days ago, runabout. So we will expect the results in the next days of the effectiveness of the containment. Next slide. So the progression was very fast, and in this slide you can see that the rest of Europe was just about 9 days behind us. And that was, the slide was published on March 9, and actually it was correct, because in the rest of Europe, everybody is following the same curve that we got. Next one. So the main concerns were related to ICU beds. We had to respond immediately to the ICU surge and medical ward surge. So, and now you can see that we now have more than 2,000 patients that are mechanically ventilated all over the country. And the huge number, we have a huge number of intubated patients in our region, in northern Italy. Next one. As you can see, the progression was really, really fast. The population of Lombardy is about 10 million. Before the crisis, the total capacity of the ICU was about 160 beds, but 90% of these beds were occupied by our standard patient, especially in winter time. So we saturated all the ICU beds quite immediately, and we started to create new ICU position, ICU beds. But every day, as soon as we created new beds, we got also saturation of these beds immediately, and that created was very hard to respond to the ICU capacity. In some hospital, we started to put ICU beds almost everywhere. Next one. So then you all know that we had a total shutdown of the country, but unfortunately some people could move to the south. So now we are facing with other cluster popping out in the southern country. Next one. So what we did just a few days after the outbreak in my hospital, for example, but I'm quite sure in many other hospitals, we immediately blocked the main entrances of the hospital. We created checkpoints. Everybody was invited to scrub hands directly at the entrance. All bars and cafeteria were closed. We created a shift to go to the in-hospital restaurant for lunch to try to avoid to get people all fully packed in the restaurant. No parents were allowed to come to visit their parents, their relatives. And each service had to identify a phone number to directly communicate with the relatives. That was extremely important also in the emergency department. So we used some resources just for communication with the relatives. Next one. What we also did, we had to stop completely education, and 10 days later, the university started again through streaming lesson. Next one. So, but what we realized immediately was the impact of the outbreak on surgery. We had to immediately cancel all the unnecessary surgery, and at the beginning we just left the surgical list open for oncologic patients. That another thing that was unexpected was the shortage of blood components, because we had less donation due to containment, and mainly because people were afraid to go to the hospital to donate their blood. And all the surgeons had, after a few days, we had to shift in other area, maybe outside our comfort zone. So surgeon started to go to help in the emergency department. And at the moment, we are just starting to lead internal medicine work. So we had to transform all our departments in internal medicine for COVID positive patient. Just to give you an example, next Sunday we will open another ward, and we will have surgeons, residents, and orthopedics to take care of this patient. We had to limit the visitors' times. We had to set up a dedicated OR for COVID positive. We had to rebuild and set up new surgical pathway. And also we, I think Dr. Bisagno might tell us something about that. We understood that also post-operative surgical care of standard patient might be challenging because they might be infected at the moment of the scheduled surgery. Next one. So we had an emergency task force for this situation. And so we had, at the regional level, we had to re-evaluate, redesign all our hub and spoke network that was mainly for time-dependent disease, but we had also to start with the hub network for surgical oncology too. And actually, this is one of the main challenge because we are considered a hub for stroke and considered a hub for surgical oncology, but actually it will be very hard to go ahead with scheduled surgical oncology procedures. Regarding trauma and cardiovascular, for example, we had to send some of our doctors outside. So we sent some of our doctors to other hospitals for the trauma hub or the cardiovascular hub. Next one. So what we had to do was to recruit new ICU beds, and that was possible using a surgical block that was completely transformed in an ICU. At the beginning, after 1 week, we started to receive the first 4 patients. Now we have 24 patients. And of course, reducing the surgical list, we had more anesthesiologists and intensivists that could take care of this patient. We planned to open a second surgical block, but that block was too near our oncology division, so we didn't consider it too safe. So we used the other area of the hospital. Next one. What we also did, as I told you before, that at the beginning, all the internal medicine were gathered together to get COVID negative patient. Now we have very few patients COVID negative. And on March 10, that was a week ago, we had 90 patients. Yesterday, we started to have more than 200 patients. Next week, next Monday, I will be leading a medical ward, another medical ward. And within next week, probably we'll have to open another wards. So the hospital is going to become a completely COVID positive patient hospital. Next one. Of course, we had to restructure the patient flow in the emergency department to try to cohort immediately our patient during the admission to the hospital. We got all the resources from the OR. We shifted the nurses to ICU and to emergency department, and we had some beds in the emergency department where we can keep a patient intubated. Next one. So we had to redesign all of our pathway this is just one example. We had to have a very simple and trying to be effective pathway. Also because you have to understand that we are using doctors that are not used to come to the emergency department. So we also have some ultrasonologists that are radiologists that are helping us. So we decided to have a very clear and easy pathway. And I think in Northern Italian hospital, every hospital set up maybe the similar pathway, maybe a little bit different. And we understood that the threshold to have a CT scan is very high, especially at the beginning. It took a very long time to have the test for COVID because we had to send all the tests to another hospital. So it took, and the hospital was overloaded. So it took out even 48 hours to have the results. So now we are using a lot of ultrasound to screen the patient and to try to redirect this patient to the right cohort. Next one. So this is just to let you know how we redesign all the pathway of the emergency department. Next one. We had to build a new area that was done in 12 hours in our hospital. I think, go ahead. Next one, please go ahead. This is the pre-triage area that was built outside the hospital. Next one. And this is the area that was built in 12 hours about 2 weeks ago. So this is the track for suspected COVID positive patient. So again, next one. As you can see, we also had a chest X-ray machine to screen the patient rapidly. Next one. And of course, we have an ultrasound machine. And then we had to use tents from the civil protection outside of the hospital with the toilets. And here is where the patient will wait to be admitted to the hospital. Next one. These are the tents where the patient are waiting to get admitted. Next one. This is the team of doctors communicating just with the relatives. And this is another area where we can get also intubated patient. Next one. So I think one of the key points was radiology education from a very early beginning, so that all doctors could understand how to read a CT scan, which is quite easy because the patterns is very, very easy. You have the ground glass area. It's 98% of the cases is bilateral and subpleural. Next one. And of course, we had also some training sessions, sorry, it's in Italian. We had some training session on how to use lung ultrasound. Next one. Where you can see the consolidation area. Next one. I think this has been very useful also to monitor the patient with non-invasive ventilation. Of course, we had to design also a specific pathway for for non-COVID patient that had to be admitted to the hospital, just for example, for an emergency surgery case. What we didn't understand is that we had a complete decrease in terms of number of patients with emergency general surgery. So we started not to see any more appendicitis, cholecystitis, very few small bowel obstruction. And really, this is something that we did not understand. So we have a very low threshold. Let's say we have a patient with an acute cholecystitis. So there is no time to wait for the test for the COVID. So we have a CT scan. because if we go to the OR with such kind of patient, that would be a disaster. So of course we have different OR. Next one. Regarding the OR setting, we had to learn from the experience of our Chinese colleague. So of course we had to set up a negative pressure OR with a very high rate of air changes, more than 20 full volume replacements in an hour. We had to understand the airflow of the OR to minimize the risk of the infection. And of course, we also had to separate the in and out access, try to protect all the OR equipment like ventilators, computers, laparoscopic rack whenever possible. Next one. So of course we forbid to we avoid to use paper inside the OR, and we had of course an established protocol for cleaning the OR, and we try to use in a very paranoid way the checklist and step-by-step instruction with detailed description of transfer of the patient to and from the OR. Next one. Regarding PPE, there was a lot of concerns regarding PPE. And this is, for example, a paper that has just been published last week from our endoscopic department, because they also had some concern. So actually our gastroenterologists and endoscopists has been very useful, because they started to run teaching lesson to the personnel on how to use PPE. Of course, in the OR, we have a quite full protection. We would suggest to have a dedicated area for donning and doffing. And what we could experience as any places in Northern Italy is that we ran out of stock of PPE quite immediately. So we have been chasing the factories to provide other PPE. Next one. Regarding the ventilation, we with our pneumologists and intensivists, we started to set up courses on ventilation with very simple module to teach doctors and nurses on how to use a CPAP. And this is something quite challenging, but we have many very lean courses, 45 minutes courses on how to teach people to use these devices. Next one. By clinical perspectives, what we have been learning is that in those patients where the NIV, non-invasive ventilation, was prolonged, those kind of patients had a worse outcome. Regarding the ventilation strategy, almost in ICU, almost all the patients, not all, but almost all, they could benefit from a proning position. Regarding ECMO, actually, I think we still did not have had any patient with ECMO, because they usually respond to simple ventilation. But I would focus with Dr. Storti and Dr. Bisagni regarding this issue. Next one. Tocilizumab, the interleukin-6, we started to use, seems to respond. I think they will start maybe a control trial. I don't know. Again, I would ask Dr. Enrico Storti to have some comments on that. Next one. So this was a report from the European Society of Intensive Care Medicine, already shared last week, but I think it's nice to represent it. Next one. I think that in such scenario, we should really start very early at the beginning of the outbreak. We should always look forward, a step ahead, try to get all the enough number of PPE. We should train. Training has been extremely important. We have been supported very much our educational and training office. Of course, we had to think about ICU areas, redesign pathway, and I think that one of the most important things was to set really clear goals for the patient. Next one. Oh yes, this is the motto of our university. Everything is going to be all right, and this is what we hope. Thank you.
Thank you, Dr. Hayato Kuihara. So I'm going to do the following now. I'm going to start to talk to call our other panelists for two, 3 minutes. Yeah.
Yes.
2-3 minutes report, and please start with the Italian, our Italian colleagues, Dr. Hayato. Then, but short report. Then we are already running delaying on our schedule. Then you can have everybody participated. Leave some time for discussion at the end, please. Okay.
Yeah. Pietro and Enrico.
Yes, thank you so much, Hayato. Just to tell you that here in Lodi, we saw something like 600 to 700 patients with coronavirus coming to the hospital. We send many patients to other ICU that we thank here for their support. And we had to face from 26 days ago with this epidemic outbreak. And actually we saw in the first day something like 50 patients coming at different hours, all with hypoxic and hypocapnic problems. And for one patient that we had to intubate quite immediately, we had 5 to 10 patients that needed non-invasive ventilation, and something like 20 to 30 patients that needed oxygen. But I will leave Dr. Storti to tell you something about it. I had to face with some cases, surgical cases, and because here in this area, actually the coronavirus, we can say, is endemic. Actually, we don't have, we don't trust so much with the test, with the rhinopharynx test, because the clinic presentation is so clear, and we use so much ultrasound, X-ray, and eventually the CT scan in order to make diagnosis, and the test we use just to confirm it, because we have some false negative tests actually. And I have to face with some surgical cases, and actually I used to have an X-ray and eventually ultrasound just before surgery, just to be sure that they don't have any pneumonitis, because in one of our cases we had from the starting something like around 50 patients. In one of these cases we have a fulminant ARDS syndrome, so we had some problem. Probably was a patient with no clinic, but something around this pneumonitis, and we had to face with this difficult case. Actually, I will leave Dr. Storti tell you something about the ICU program. Well, I just tell you that we completely redesigned the hospital. Actually, we have something like 180 beds used for sub-intensive care, and we passed from 7 intensive care unit beds to 24 intensive care unit beds. But I leave Dr. Storti tell you about it. Enrico, hai tu?
Sì, sì. Okay, thank you so much, Ayato, for your comprehensive presentation, which has been a really nice introduction. And also I would like to thank also Pietro Bisagni for not only for being here now, but for being beside me from the very beginning of this, let me say, nightmare. As Pietro mentioned, I would like to give you a very rough idea about what is going on here, and I don't know if I can share my desktop. Let me try if it works. It works. Okay. Can you see?
Yes, you can see your screen.
Something.
Yeah.
So this is more or less the situation. In green, you have the people who became negative. In white, you have people died, and in red here, which is a 31 and 500 more or less are the total patients positive. This is very roughly the figures here in Italy. And as Pietro mentioned, if I manage to do this, okay, this is you know, a sort of forecast of what about what's gonna be the ICU patients in the ICU needs in terms of taking care of our patient in Italy, and this is more or less the figure until 2 days ago about what is you know, the impact about the ICU capacity in Lombardy, in our region. But what is in my humble opinion very important to clearly understand what's gonna be the impact here in Italy or wherever we are or you are in the middle of a coronavirus outbreak, is that this what we call double time, the time to double the figure about the ICU demand in terms of beds and patients, of course. And you see that is a very short time compared with all the organizational issues related to enlarge the ICU capacity, and this is exactly what we have been forced to do without stopping the hospital ability to take care of our patients. So this, believe me, has been a real challenge. And as Dr. Ayato presented before, whoever has a few days ahead of the outbreak, I think that has to get ready in time, because what has been asked to the physician is to completely change what is the ICU capacity. And to give you a rough idea, we enlarged our ICU starting from the average 7 beds we had before. Now we have 24 ICU beds running, and believe me, this is a huge challenge, because not only we have to, and we have been forced to enlarge our ICU beds, but also we have to run this issue with a staff which has been decreased more or less the 20-25%, because we have positive colleagues, positive ICU physicians. So this is something that, believe me, it's really challenging. Anyway, let me also talk about how we have reimagined and reinvented our hospital, because now after 3 weeks under this kind of pressure, this kind of patient has completely reinvented our hospital, starting from the emergency department, which has been not only logistically changed and reimagined, but also from about the way of taking care of our patients. So we have created a new area where we have referred all the ventilated patient, the more sick ventilated patient. And let me say, I have some slide here. Wherever you see here, this is our ICU that has completely been enlarged. And you see that this is the kind of impact in the emergency department. These are not the usual rooms we use. This is only the aisles in our emergency department, completely occupied, filled up by patients. Wherever you go, you can find patients. And you can also see here on the right side here, these new these new oxygen sockets, because under this impact, we have been we had some problems with the oxygen pipelines, whose become completely insufficient. So there was some concern about our ability to meet the oxygen delivery needs. And believe me, this has been a nightmare, because when you have 82, 83, 100 patients completely depending from ventilation or simply oxygenation, you can imagine what a oxygen supply problem may mean. So this is our emergency department completely changed, and let me thank here our emergency physician, Dr. Paglia, and he did an amazing job in completely change not only the logistic issues, but also the crew and all the duty of the different emergency physician inside the emergency department. This is another crucial point, how to connect and how to stay connected with step-down units and ICU units with the emergency department. If you have no disconnection, you lose the contact with the front line, and this is for the intensivist a sort of disaster, because you have to take care of your 24 in our hospital ICU patient, but you have also to assess not only day by day, but hour by hour, the number of patients that you have to take care in the emergency department and in the step-down unit. In terms of hospital logistics, sorry?
Enrico, we have to move ahead. We have to move because also the other panelists have to talk. Okay, no problem. Sure. Okay, so let me only 30 seconds to close. So we have created a step-down unit, 20 beds more or less, that starting from the scratch in 2 days. And we created 2 different medical beds worth for a total capacity of more or less 100 beds. And here we ventilate the less sick patient or simply the patient who needs oxygenation. So thank you for giving me this opportunity to talk about what we did in Lodi. Thank you, Enrico. Thank you very much.
Okay, great.
Dr. Hayato, anybody else in Italy, please? Dr. Hayato?
Mauro?
I have a question for my friends in Lodi and to Dr. Zhang in China, because one of the main issues is the shortage of protective personal equipment. We really had very critical days 1 week ago, and even today is not very simple. I would like to ask them if they had the same problem and how they address it, and to Dr. Zhang if they have in China similar problem, and if they how they let me say tailored the use of PPE in their hospitals.
So Dr. Zago, let's do the following. So we're going to have discussions at the end. So everybody, please make your questions the Q&A box. There's a box at the bottom of the screen. Make your question the Q&A, and then the panelists can start to answer these questions to everybody typing that. In the meantime, I'm going to go over all the panelists for 1-2 minutes report for your vision. And then afterwards, I'm going to start to have all this discussion. I already saw very interesting questions in the Q&A, okay? So anybody else from Italy, Dr. Hayat? So if not, I'm going to go to the panelists. Okay.
No.
So let's go to the panelists in order that I have here. So please, let's start with Dr. Tercio de Campos from Brazil. Dr. de Campos, your quick report from situation in Brazil, main challenge and lesson learned, please, and planning for the future.
Okay, hi everyone. Thank you for this wonderful experience. We are very concerned here. We have right now 367 patients, 21 new cases, and 1 death. The first cases we received in private hospitals. The public hospitals are suspending their procedures to wait for patients to arrive. We believe in the next 2 weeks it will be very concern for us, and we're learning from the experience worldwide. That's what we have right now.
Okay, Dr. de Campos from SBITE in Brazil. Next one I have on my list here is Dr. Foianini from Panamerican Trauma Society, talk about the situation in South America. He's from Bolivia. Dr. Foianini, please.
Yes, Dr. Marttos, thank you so much for the invitation. So the situation in Bolivia, we are far behind what's occurring in the rest of the world. Up to this date, we've had a total of 12 patients in the entire country. 4 of them are from the region of Santa Cruz, Bolivia. 1 of them was diagnosed at our institution. We do not have any native infections, meaning that all of them have been people who have come from outside of Bolivia. They are Bolivian nationals. 1 of them came, that I'm aware of in Santa Cruz, came from northern Italy, was a caregiver for a gentleman who passed away in Italy, and then she decided to come back and actually was received by her family and taken to a rural community where they had a family gathering. So that created some real issues. She was the first case in Bolivia. Furthermore, there's clear panic amongst the population. She was then transferred to the main city of Santa Cruz, which is a city of 2 million people. And none of the hospitals wanted to accept her. Actually, the ambulance was hit by stones. And then it highlights issues with education in our population. We recently had 1 individual who came in from Madrid, who works for a company and was on a business trip. So well educated. Despite that, he had a social gathering, got together with some friends, and then that's created some more issues. So the containments that we're trying to do, and there are some arguments between the central government and the state and city government, but they've implemented a shortened work week, work hours, so only from 8 a.m. to 1 p.m. And then you can actually, there's curfew after 5 p.m. in the afternoon. So right after this meeting, I have to go to surgery for a patient with acute pancreatitis. And so I'm gonna try to make it out of here before the curfew's done. So they started implementing some of these issues. They've actually closed down the borders. There's gonna be no further international flights after 72 hours from now. And there's some talk about cutting down interstate or interdepartmental travel also in Bolivia.
Okay, thank you very much, Dr. Foianini. Dr. Zhang from China, your 2-3 minutes comment, then go have your discussion at the end, please.
Thank you. Yeah, this is Dr. Zhang from China, from Shenzhen. So China is the first country for the outbreak, and so far there's total more than 81,000 patients infected, and with more than 3,200 deaths. At the moment, there's still more than 8,200 infected patients in hospital for the whole country. And the severe infected patients in ICU is more than 2,600. Now seeing the situation in China is getting better, And today, such as today, for the whole mainland China, it only 13 new cases happened for the whole country. And the whole country is going back to the normal life slowly because the cases is getting stable. And the challenges we're facing now at the moment, as just mentioned by Dr. Zago from Italy, we're still short of protecting materials as well. It's getting better at this stage, but still is not enough the protecting material. And the government is encouraging, helping the company to produce more mask, more protective material for the country and also for outside the country. And the lessons learned, I think, is the most important in China is the early control of the situation is very, very important. Because at the early stage, very early stage, the work has been done is not very properly at the very beginning. So that's caused a lot of medical staff infected. It's more than 3,000 medical staff infected in China. And that's quite many died by, I don't have the exact number, I don't know exactly how many died, but there's some medical staff died and some police died as well because that's too much work for them, overwork, and that's too tired for them. Some police died as well. So the most important thing is to identify the infected patient, to suspected patient, and to isolate them. This is very important in order not to spread, let them to spread the virus to other people. And the main point, this is the main point in China to control the situation. One of the things is we need to have the enough capacity to isolate the patients. So many patients, so China has been done is set up a lot of new hospitals to isolate the patients. All the sick patients, infected patients sent to the dedicated hospitals. And a lot of medical staff from all over China, they go to Hubei, go to Wuhan, they bring all their ventilator, their PPE, they bring a lot of things from their own hospital, going to Hubei and Wuhan to help. And this is what we have been done in the past few weeks in China. And the team leader, the medical team leader in China, is Professor Zhong Nanshan. He mentioned today from newspaper, he said he think that from the experience from China, if there's no strong intervention, he does not think the COVID-19 will disappear by itself. So he strongly recommends we need to do something we can to proceed to perform a strong intervention for this outbreak. And that's a new good news from Italy today. The newspaper shows that aggressive testing helps Italy to cut new COVID-19 cases to zero. It means to test the patient, find the patient, isolate the patient, and treat the patient is the most lessons learned in China. So for the planning, at the moment, China is going back to the economy. The economy is affected significantly. So the government start to help to bring the economy getting normal. Also, we follow any new cases. If any new cases, we will follow completely where the cases from who is contacting the patient to isolate the patient to make sure the things is not getting worse again. So again, for Professor Zago, China now is more try to produce more protective material, mask, gauze, and other things. Still very tight for us. It's not. It's impossible for us to buy the things from the market, but the hospital they can buy the material. So it's still not enough in China, but I think it's getting better. It's more products is producing at this stage. Okay, this is what I'm thinking. Thank you.
Thank you very much, Dr. Zhang. So let's keep going. Just to let everybody know, since the meeting is very interesting, I'm going to extend this for half an hour, okay? Now I'm going to have Dr. Michel Aboutanos from VCU Virginia. He's the chair of the WCTC International Committee. He's going to give the report for 2 other countries. He's going to talk about Australia and from Africa, and he's going to mention also all the participants of this coalition here. Dr. Aboutanos, please.
Yeah, thank you. Thank you for putting this on. As as you know, and many other people already know, the International Relations Committee, we have actually in the past week and a half been getting on a daily basis reports from all our colleagues. So far, we have people from South Africa, Qatar, China, Italy, Norway, Germany, New Zealand, Australia, Kenya, multiple centers in the United States, and Brazil. And just looking at the QA questions, sound like we need to share a lot of the information, not just with who's coming on society. So we're going to be putting a report and trying to figure out how we could share all of this. So this conference is incredibly important. But the various societies already logged on, and including the Australian Trauma Society, European Society, AAST-IRC, Japanese Society of Acute Care Surgery, and the International IASIC, COSEXA, and ISS, the Trauma Society of South Africa, and Indian Society of Trauma Acute Care, and World Society of Emergency Surgery, all of which have representatives that have contributed so far. So we'll make this more available. But before I give quick report, I hate to give report to someone that's already maybe online. So do you know if someone is already online from New Zealand that could themselves give a quick minute report, or I could read what have been sent to us?
Just quickly, anybody from New Zealand? So Michael, since you are already late, just quick read, and then next week they can give the report probably, please. Okay. This is a report that we got from Ian Seven from Australia, from Dr. C from New Zealand, and this is please note that this is only 2 days old already, so I'm sure a lot of things have changed. But they had about this is in Australia, about 12 cases confirmed, all from overseas, similar to what was noted by Dr. Fionini, that many of those are not natives that came from U.S., Qatar mainly, and none were hospitalized so far. They have shut down all their schools, but few are still open. The corporate business is also has greatly been reduced, and so have the flight domestically have been reduced, similar to what happened in many other countries. The addition that came from Dr. C's report that they think they're behind with regard to their rate, but they expect that to increase in the next week or so. At the national level, all arrivals to New Zealand will need to be self-isolated for 14 days, irrespective of citizenship. There's law-enforced quarantine or deportation to those breaking the rules, so a very strict structure. National hotline is short of volunteers. All the ventilators are being sourced in both public and private sector. So they also similarly have significant amount of worry about shortfalls in PPEs and N5 masks. At the hospital level, the first New Zealand COVID case was managed in Dr. C's hospital. There's an increased number of probable cases. They've all been awaiting confirmation. They have increased their ability to test for COVID from 500 to 1,000 a day within the hospital and in-house. So the COVID surgical protocols were put in place, and I know there's been a lot of QI about sharing these protocols. All the clinics are being converted to virtual or phone follow-up if we can. All elective surgical lists on monitors are only for high levels. They shut down all the clinics and elective surgery, but they're doing that only once there is confirmed community outbreaks. So that's another lesson we could discuss. They've sent home all their students and observers, and they eliminated all face-to-face handover meetings. So and they comment that this is very uncertain time. So this is from the report from Australia quickly and from New Zealand. I could give, if nobody else is online, also the report from South Africa, unless Dr. Beaufort is already online, you want to ask? Ken, are you online? Can you give that report yourself? Okay, I'll keep going then. Very quickly, just very quick short report. This just came yesterday from Dr. Beaufort. So in South Africa, they have 62 confirmed cases, no deaths so far. They have, of the 62, 61 were imports, again, returning predominantly from Italy, but from Switzerland, Austria, Germany, UK, and the United States. All were initially placed in hospitals, but they
asymptomatic or self-quarantined. He stated that we have placed an early New Zealand-style policy in place. Air travel, internal and external, are banned for non-urgent work from home. All meetings more than 50 have been banned. All sporting events and gathering of all have been, including church activities, have stopped. And all the schools are shut down. And he thinks that they have a significant advantage because they started preparing 6 weeks earlier because they're 6 weeks behind China. Here's the biggest challenge, which will be important, that 15% of the total population are HIV positive. They're all on, currently all on ARV treatment, and this free treatment. He's not sure where this is gonna go. Another problem, which we've heard also from Kenya about and other places, 29% of the working population are unemployed, most in poverty, so many with unreliable water for washing. So this is another major event. And the major public transport system is also crowded in many places, and they don't know how that could be contained with potential for gross infection. So demonstrating other issues that are already present besides the COVID-19. And basically he commented on close guidance and proactive intervention from the National Institute of Communicable Diseases. And he commented that they have a lot of experience already in South Africa from Ebola, from the Marburg, from Lassa, and listeriosis, with that been having huge success in tracking those, and he hoped that would be extremely helpful. I'll stop there because there's a lot more to go to give others opportunity.
Okay, thank you, Dr. Aboutanos. Now, Dr. Rizzoli from Qatar. Dr. Rizzoli, how is the situation in your region, please? Gary, can you unmute Dr. Rizzoli, please? Valera, Gary, please unmute Dr. Rizzoli. Dr. Rizzoli, go ahead, please.
Antonio.
Yes, Nick.
Dr. Rizzoli typed in the panel that he's unable to unmute his microphone, but his only comment is that the same measures instituted in Italy were implemented in Qatar, including closure of the borders and airports, but the difference is they started their measures when they only had 3 patients.
Okay, thank you very much. So Dr. Tina Gardner from Norway, please, your report.
Can you hear me?
Yes.
Okay, good. So I'm impressed with all the reports so far and impressed with the challenges Italy has had. And I think, so we're in the same region, just at the other end of Europe. And that means we are quite a few days behind, which has given us a little bit more time to prepare. What I can say from our part, is a small country, 5 million people. The policy has been focusing on aggressive testing and an aggressive and rigid tracking of contacts, and following all. I'm not going to copy or to repeat what has been said. I think everything that has been said from Italy and the others has been implemented here as well. What we see is that so far we're probably on just started the exponential rise of cases. We have 22,000 people tested so far, 1,300 cases positive, 140 last 24 hours. We have 6 deaths, and the last 2 is these last 24 hours, with still few patients in ICU. And not that many patients in hospital, but what we see is that most of them have been contaminated abroad, and of the 760 contaminated abroad, more than 500 were contaminated in after-ski in Austria. So we see it all describes a little bit the pattern of people's traveling habits. We have 5,000 undiagnosed and suspected cases, with lots of people in quarantine. That is challenging the hospital staffing, obviously. We see, so our borders were closed yesterday. All meetings and everything else has been closed down very strictly. I think the only thing we don't have is a complete curfew. So what we see is for the hospitals, I think one of the challenges that hasn't been mentioned is the challenge of disciplining the teams and the use of PPE, because people are scared, and that means to be able to define really which patients, because we're at the beginning and there are still relatively few patients, and not to use everything. We were already short of masks and gowns a couple of days ago, and there's no way to find it. Even if Norway has a good economy, there's no way you can buy it or find it anywhere. So, so trying to get people to understand the rules and how we actually do this in a reasonable way has been and is a difficulty, especially when the teams are multidisciplinary, because they get information from different sources. Apart from that, I think teaching and trying to get people into like was mentioned by Hayato, to try to teach people to become a different profession than what they have from before in order to fill in the gaps is difficult and in this situation, but there are lots of efforts to do that. And but like we see, so critical roles like trauma surgeons and so on and so forth, if you don't have enough of them, and there's not, like right now we have more than half out in quarantine, you need to try to get people up to speed very quickly. I think apart from that, everything else has been mentioned by everywhere else. One thing is, I think it would be nice to discuss at some stage, what are you guys doing with data collection in order to, because to have, one thing is sort of registries for all other kinds of activities, but how good are we at prospectively gathering the data in a situation where we want to use people for all the other necessary work, when we want to have data to publish later on for the messages and for the learning points. Thanks.
Okay, Tina, thank you very much for your comments. So now I have Dr. Scalia, the Executive Director of the Panamerican Trauma Society from Shock Trauma in Maryland. Dr. Scalia, what's the situation in the Washington, Maryland, and Baltimore region, please?
Hear me okay, Antonio?
Yes.
You hear me? Wonderful. I want to thank everybody for joining in. We're very pleased that the Pan American was able to host this. It's greetings to all of our colleagues around the world. It's remarkable that though we practice in very different locations, the solutions seem very much the same. We are just, the surge hit this morning, so we are just taking off, and we hope we are prepared. I'm not sure you ever can be as prepared as you need to be. I would offer several perhaps different perspectives. One of the things that exist in the United States are hospital systems. And we have at Maryland, for instance, a 16 hospital system. So rather than trying to solve all the problems ourselves, we are franchising a lot of this around the hospital system to try to concentrate the sickest people in the medical center, but care for the vast majority of people in the community hospitals. So far that has worked, but as I said, we're just hitting the accelerator, and it's a little hard to know how all of that will turn out. Regarding personal protective equipment, we are also having the same problem, and we are now engaged in a discussion as to how we are going to limit participation of students and or residents in trauma care, simply because we can't afford to utilize all of that PPE for everybody to gown up to help care for patients. I would also really encourage everybody to stay as involved as they possibly can in their individual hospital planning. As we started to roll this out, we did it very badly at the beginning because the administrators and the infectious disease people were really running this, and they don't run hospitals. They don't run clinical care in hospitals. And so we had to go back and redo a lot of the algorithms that we had created because they look good on paper. They just didn't actually work. And it turns out to be an all-encompassing job. Trying to do this in between patients is virtually impossible. And so creating some clinically active people to really run this for the hospital, in my mind, is critically important. And lastly, we have run into some specific issues around trauma patients we hadn't really anticipated. The first is airway management in the trauma patients, because many of the people we see come in and are not awake and not able to give us history. Isolating those people in the emergency department is very difficult. So we have now created a process to get them out of the resuscitation unit and up into a safe bed. We've changed the way that workflow goes. We have started using it as of this morning. Hopefully that is going to work well. And just thank you, Antonio, for all of the effort in putting this together. Hopefully we can educate one another and do better than we would have done by ourselves.
Thank you, Dr. Scalia, for comments. We're going to make these meetings weekly for some time. So now I'm going to have the questions. I think you can go for a few more minutes. I'm going to ask Dr. Namais to help me moderate these. We had 21 questions. Let's try to go ask let's ask the physician from Italy and from China to answer, since they have the most of the experience. I even saw some questions regarding how to manage the correction decisions system. So let's start. Dr. Namais, please help me. The first question regarding ARDS from VCTU Health. So, Dr. Hayato, your comments, or our physicians from Italy, the intensivists. The first question, do you have any experience in high dose intravenous vitamin C? Did you check vitamin C levels in a patient with severe disease? Do you use steroids for ARDS? The first questions from Virginia, Dr. Hayato, and our friends from Italy, please.
Enrico, I think you can answer to that.
Yes, I think that we have a huge number of real and true ARDS, where the earlier is the incubation process, or just like we have been trying to do, try to ventilate non-invasively this patient, not because this is the gold standard treatment, but just because we had too many patients at the same time to treat. So we have been forced to intubate some patients and to ventilate non-invasively other patients in order to give them time, to buy time to enlarge and to try to transfer a portion of our patients. So we had a huge number of ARDS patients, definitely, and we do not use at the moment steroids in our therapy set, to say. Otherwise, we are also using all the tuchizumab therapy, and we are in a experimental model trial with 45 patients, and we start enroll the patients tomorrow, because we will receive the drug tomorrow. So I can promise you that in the near future, I mean in the next 15 days more or less, we can tell you something more about how this antibody is working in terms of reducing the lung damage.
Thank you very much. It has been very hard to hear you. Maybe you have some more problem with your
microphone.
Thank you very much. It has been very hard to hear you. Maybe you have some more problem with your microphone. So, doctor, another question: any measure of IL-6 level, D-dimer levels, and sprinting tocilizumab? So, any second question, please, Dr. Hayato and anybody.
Yeah, I think what we have seen that many patients, they come with the high level of the dimer, and actually it's one of the you know, they start to use I don't remember the name of the drug for the anti-rheumatic drug. They start to use the anti-interleukin 6 when the D-dimer decreased, actually.
Thank you. Gary and Valerie, please record those questions. We're going to try to have all these answers published in the Panamerican Trauma Society website also, please.
And
next
Antonio,
question.
Antonio,
yes.
there's a very practical question here that a lot of people could use to take action right away. An anonymous attendee asks, what about the utilization of ultrasound versus CT scan? What is the sensitivity and specificity of the test? And I suppose, you know, this follows what we heard earlier about when you get really busy, the diagnosis becomes clinical, and the ultrasound is immediately available to all of us. Do any of the panelists have great experience with ultrasound? And can you tell us what about the finding on ultrasound would differ from other lung pathology to tell us, hey, this is COVID?
Mauro, would you please reply to this? Mauro, can you reply to this? You want to reply to this question regarding ultrasound versus CT scan?
So I think that the largest experience in this field is from Enrico, because Enrico is an intensive founded together. We focus, I'm sure that he has more experience than me in this field. What I can say is that the methodology of lung ultrasound, basic lung ultrasound, is very simple. So it could be even learned very, very quickly, even in not experienced people, at least for a yes, no, first yeah, in this setting. But Enrico, I'm sure that can give you more precise answer.
Yeah, thank you so much, Mauro, for this assist. Yes, yes, definitely yes. We have chosen point of care ultrasound since the very beginning of our patient pathway and treatment, just because we definitely know the CT scan is a gold standard for IRDS or for severe lung involvement. But let me say that when you receive 50, 70, 80 patients at the same time in 3-4 hours, you have no time to use CT scan. And we did simply in a point of care fashion. We use blood gas analysis as chest X-ray and lung ultrasound at the same time in order to identify different degree of lung involvement. And I promise you that ultrasound, lung ultrasound and chest ultrasound is perfectly working in order to better address where to send the patient, when to send the patient, and also in terms of monitoring the patient in the emergency department or in the step-down unit. So I really do advise to use ultrasound since the very beginning of the clinical pathway of the coronavirus positive patients. And I promise you that this has been the real solution for us, because if we compare our hospital with the nearest hospital who's chosen to use CT scan in the very beginning, they have been overwhelmed in hours, just because when you receive 150 red codes or yellow codes, so the sickest patient, the CT scan is a sort of speed limit for treating a huge number of patients. Also because the IRDS presentation in terms of symptoms and in terms of signs and in terms of ultrasound findings is pretty clear. So it's not so complicated merging together all these clues.
Thank you very much. It has been really hard to hear. Dr. Namaz, I have a question. Next question, I'd like your initial comments, then go to Dr. Hayato. So what you're doing to screen patients with possible COVID-19, and how to protect the trauma teams and the healthcare professionals to be contaminated, and also then afterwards for Dr. Hayato, any data demographics of intubate patients, ECMO deaths, and how to and number of healthcare professionals infected, please.
Unfortunately, after we had the outbreak, the trauma case really were completely reduced. Very, very few trauma patients, very few appendicitis, very few cholecystitis, but also very few injury due to the containment strategy. The problem is that we are starting to have a lot of infection, quite a lot. I don't have a percentage, but we have 5 of our surgeons that are at home because they were positive, 1 neurologist, 2 ER doctor, quite few nurses, and a couple of oncologists. So this is regarding it's a problem for staffing, for the staff, because they're all fine. A couple of them, they were admitted, and one of them is discharged. Actually, one of the urologists, he's in the ward now, and he's assisting patients anyway, as patient. So this is the main issue. We have a lot of concerns about that.
Okay, we are seeing here in Miami, and I think some other centers in the United States, people start to be contained at home, and the violence is increasing. The number of gunshot wounds is increased at this moment. Maybe later going to drop. Dr. Namais, how is screening patients and how to protect healthcare professionals?
Thanks, Antonio. So what we've done, our trauma entrance is separate from the emergency department entrance, and we have 6 EMS agencies that deliver patients to us. We've asked those that are able to measure a temperature on the truck on the way to the hospital. And for those that can't, we send a nurse or a tech outside to check a temperature. If the trauma patient is febrile, we have a specified trauma bay for them where we will treat them as if they were COVID with full N95 PPE. If they're afebrile, we just use the normal PPE. The minimally injured patient who is where the risk for COVID exceeds the risk for injury, like a fall with maybe an isolated hip fracture, would be transferred over to the emergency room for where it's more focused on COVID and negative pressure rooms. So we're the main thing is we're screening temperature in the truck on the way to the hospital.
Thank you, Dr. Namais. Dr. Hayato, demographics of the patient are intubated, the patient they went to ECMO, and demographics of the ECMO the deaths, please.
No, till now we had no ECMO patient, 0.
Okay, why? They don't fill the protocol, so what would be the protocol to get ECMO?
I'm not an intensivist. I've been discussing this with our intensivists. They respond to simple ventilation, to protective ventilation and pronation. The only problem is that as soon as they stop the pronation, the patient starts to worsen. Till now, what our intensivist told me is that they had the patient that we had no indication for ECMO till now.
Okay.
And okay.
For the patient that died, so any group, a specific group, and any comorbidity that you can tell us. So what is
all patients? The patients who died in my hospital, at least, they were quite compromised in my hospital. But I know that maybe in Lodi, situation different. I don't know in Lecco.
Okay. Another question. So didn't you receive any events, other supplies from the government, from manufacturers? So how are you receiving more equipment, more beds? So how is the hospital managing that to increase the beds and the response?
Well, I'm working in a private hospital serving a public. So we didn't ask for extra resources at this moment. Actually, we could send some ventilators to another hospital still of our group in the Bergamo area. But I think that the emergency crisis task force, I think that this week they recruited 500 ventilators, as far as I know. I'm not sure. Pietro or Mauro or Enrico have data about that?
Sorry.
Yeah, it's very hard to hear you. So let's keep you. I'm going to ask Dr. Zhang from China. Did you use ECMO? Which patient did you indicate ECMO in China, please?
Excuse me, I beg your pardon. I cannot hear you just now.
Yeah, what kind of indication do you have for ECMO? Did you use ECMO in the patients with severe respiratory failure, ERDS, and what kind of indication? What are the patients that went to ECMO?
Yes, I work in Shenzhen, and in my hospital we don't have COVID-19 patient actually, but I saw from the newspaper and the report, many colleagues from Wuhan actually they have been using quite a lot of ECMO, and such as in a hospital in Wuhan, Tongji Hospital, there's many ECMO machines there because some from hospital, some from other hospitals brought to the hospital. For the patients, if they using the normal ventilator, is not effective also with the lung failure, and I think it is one of the indications for them to use the ECMO. I had not participated the detailed work for the ECMO, but I think for the ECMO machine, it's quite a lot out there, I think.
Okay, so this is going to be a topic for next week. Let's try to have people share their experience with ECMO. I have another very good question. So how to manage the outbreaks in jails, in prisons? Dr. Hayato, what happened in Italy, maybe what happened in China? So how to manage this special situation? A lot of people in the same place, and how is the healthcare for these patients?
I didn't understand the question, sorry.
So what happened in the jail system, the prisons? The prisoners, the people incarcerated. So what happened, how to manage the situation? Do you have any special outbreak, a bigger number of contamination, etc.? Infected?
I don't know how to answer because the only information that I have was from television. We had quite a riot a few weeks ago in different jails, but to tell you the truth, I didn't listen to that. So I have no information on that.
Dr. Zhang, anybody else from Italy? Dr. Zhang, any information about this in China?
Yes, you mentioned the infected medical staff. Yeah, I beg your pardon for questions again, please.
So how do you, any special or high number of infection in the jail, in the prison system? And how to manage that?
Okay, you mean how to manage a lot of infected patients? Yes, I think in China they dedicate particular hospitals, such as they build 3 dedicated hospitals in Wuhan. Is very strong. Within 1 or 2 weeks, they build 3 dedicated hospitals there, where every hospital has nearly 1,000 beds there. And they bring all the ventilators, all the equipment from everywhere in China, and they put together, and they made the hospitals running as soon as possible, very quickly. And then bring the team, the whole team from the ministry or from the province where have good healthcare capacity. And they bring a big team there and to manage the whole work. If they're doing the things, is doing the whole work, the whole hospital can be managed by the ministry. And then another option is the whole work can be managed by a particular hospital. Another things they are doing is such as in Shenzhen, the Shenzhen city, they need to take the responsibility to help a particular city in Wuhan, in Hubei, something like that. So it's a group of people go to Wuhan or Hubei to manage a hospital or a ward or ICU unit, something like that.
Okay. So I don't know Dr. Liliana is here, but Dr. Namai, is any plans? Do you have any plans for the correction system?
I'm not aware of plans for the correction system. I just wanted to point out a great question that's in the Q&A if you haven't seen it.
Sure, go ahead, please.
So from Florestano Constanza, they ask, do you use neuromuscular blockade before prone ventilation or just sedation? So our centers that have been proning people heavily, just sedation or paralysis?
Dr. Hayato and Italian group.
Enrico, can you reply? Is it just paralysis or sedation?
Before proning, right? I think they're having issues with connectivity.
Okay, here we are. Yes, I think that we use both sedation and paralysis, and paralysis is needed especially in the early stage of ventilation, just because we have to drive the ventilation treatment, and so to be sure to be very highly protective and control the PEEP and recruitment maneuver. So let me say that IRDS needs a huge ventilation control. So we try to use both in the early stages, and when the patient is improving a little bit, we try to stop paralysis and manage the patient with sedation only. So this is more or less what we are doing.
So there's also a question about high flow nasal cannula usage and risks. We heard early on that we should be avoiding non-invasive ventilation because we'll be spreading aerosol. What are your thoughts on non-invasive ventilation, including high flow nasal cannula? Same question for our busy Italian colleagues. High flow nasal cannula or no?
Yeah, what I can say, I'm Mauro Zago from Lecco, so I'm not an intensivist too, but I can say that in our hospital, there is a low threshold for the use of non-invasive ventilation. There is a kind of test based, like Ayato showed you, based on the oxygen saturation, and they try to put very quickly, if the patient is not responsive to oxygen administration, is to go ahead quickly with non-invasive ventilation. But non-invasive ventilation is maintained if there is no improvement. Again, low threshold for intubation. I don't know, but it is. I am reporting what our intensivists are doing. I think that again, Enrico, who is among the Italian connected people, the only intensivist among us, could be give you a better answer.
Yeah, just to complement this, so about high flow nasal cannula versus when to intubate, and usually the patient that recover, how long do they need to be intubated? And the patient that died, usually at how long, how many days in the ICU intubated they last until they die, please. Dr. Hayato and our colleagues.
I didn't understand the question, sorry.
So usually say the patient that recovered, for how long do they need to be intubated? 1 week, 2 weeks, 3 weeks, for how long to have the recovery? And the patient that are dying, usually they die after how many days intubated in the ICU? How fast is the outcome or the bad outcomes?
Yeah, they remain intubated quite a while. As an average, I would say at least 10 days up to 2 weeks, mainly. and we have a huge problem discharging this patient. I know from the experience from another hospital, which is Luigi Sacco Hospital, they have a very long time of recovery, especially, of course, elderly patient. Just to give you an idea, last week we had 90 patients. We discharged about 15 patients till now. I think today maybe we are going to discharge other 5 patients.
Okay, thank you. A question about surgery. So should the surgeons go to operating room and do procedures with full PPE and with the mask? What kind of mask? So, and how does this patient, surgical patients, do in the post-op?
Regarding the facial masks, so we are all obliged in the hospital to use surgical masks. Everybody. Regarding the next level of protection, the intensivists and anesthesiologists and all nurses that are taking care of airway, they use FP3. And when we are in contact with this patient in the emergency department, we use FP2.
Okay, thank you. Nick, any other interesting question, please?
You caught me off guard. There's a lot of great questions.
Yeah.
There's requests to see the recorded version, so if you can assure them that a link will be sent out to the recording, is that going to be possible?
Yeah, sure.
Yes. So have another question about when you need to do tracheostomy, do open, percutaneous. So have you been doing tracheostomy with patients or keep them intubated for a prolonged time? So any change in the protocols for early tracheostomies in these patients? Dr. Hayato?
Yeah. Yes. Quite early, but I don't have the numbers on that. I know that in Lodi, you had quite a few tracheostomy, isn't it? Enrico and Pietro? Pietro, can you hear me? Pietro and Enrico. So, Mauro, you have data about that?
Not data, but a few patient needs really tracheostomy. In comparison or to the number of patients admitted to intensive care unit.
Okay.
And Antonio, there's a good question about N95s with everybody being short. Is anybody reusing N95s? And if so, how are you sanitizing them? How are you cleaning them?
No, we
Yes,
don't.
one thing is use the electro driver. Yeah, there's something to dry our hair. The driver to this the N95.
So you're cleaning them with the soap and water or alcohol, and then blow dryer.
No. Only the driver, only the electro driver, just the heat.
Just the heat.
Just the heat.
And is there any evidence for that, or are you just hoping?
Well, some article is talking something about that.
Okay, thank you.
Dr. Hayato, there's a question here about healthcare providers getting infected. So your comments about that, please. How to prevent, how to be sure that you are doing everything. And when the PPE goes low, so what can be done to avoid the healthcare professionals to become patients?
I think that one of the most important thing is regarding dubbing and swabbing, dubbing and doffing. I think it would be extremely useful to have always somebody that might help you to take out your PPE. unless it's so easy to get contaminated. And so that's why you should have set up a dedicated area when you take out your protection. And please move a step forward to get a lot of antiseptic solution to scrub hands, because also regarding that, we went out of stock immediately.
Yeah, in China, because the PPE is not enough, quite a lot of medical staff they wear the PPE and they cannot eat anything, they cannot drink anything. They work for the whole day, and because if they eat or they drink anything, or if they go to toilet, they have to change the PPE, and that's no more PPE for them. Many of them they only have one for a whole day. So many of them they just don't drink, don't eat for a whole day, and they use the pad and they go to toilet. They just inside the PPE, something like that. Yeah, very hard time.
Okay. Yeah, so have been multiple reports of shortage of PPEs in multiple places. This is an issue for healthcare providers. Okay, any other relevant questions? We are running out of time here. So we're gonna try to record all these questions and try to answer, and we're gonna try to put this webinar available at the Panamerican Trauma Society website. So Dr. Myers, did you see any other question for now?
There's a lot, but we're over time, and
yeah.
I think that we should save them, collate them, and maybe collect some answers from the panelists or any expert by email. Some people asked, what's a good source for information? I felt like the best journal there is right now is Twitter. Find yourself some doctors and follow them, and follow the people they follow, and follow the CDC. And then be careful about what you believe and what you don't believe. But, you know, I've discovered things from Johns Hopkins, from the CDC, from the World Health Organization that I would not have come across by myself without the suggestion from colleagues on Twitter. So medical Twitter is really helping right now.
Okay, so we're gonna record all this question. We're gonna gently ask our friends from Italy and from China and the panelists to answer most of these questions as much as they can. Then we're gonna publish this, and some of these questions are gonna be addressed next week, Wednesday, on the next conference. Okay, Dr. Hayato, our friends from Italy, all the panelists, I really appreciate your time. I know they are all busy. I think this is a very important collaboration, global-wise collaboration. Let's keep doing this for the time being until we can win this war against the COVID-19. Thank you very much, everybody. I hope we can see you all next week. Dr. Hayato, your final comments, please.
Thank you to you, Antonio. I think this web call is a fantastic tool. It's really very helpful. We still have so many concerns. We would be really pleased to share with this fantastic international community. And would please just let me have a special thanks to Enrico Storti and Pietro Bisagni, I think they need a virtual applause for that. Thank you.
So thank you very much. See you all in 1 week. Take care.